Good morning, my name is Araceli Muñoz-García, and today I'm going to talk to you about Epidermoid Cyst of the Anterolateral Cisterns of the brain stem with a Subasterional Approach block type. I'm from the research unit of Neurología Segura from Angeles Hospital in Morelia, Mexico, and we do not declare any conflict of interest. The tumors of the cerebropontine angle are a group of tumors located between the tentorium of the cerebellum, the pons, and the tip of the petrous bone. They represent about 1% of the intracranial tumors, with the epidermoid cyst being half of them in our series. These slow-growing tumors have an embryonic origin and manifest symptoms in about decades of life. About 1.5% of our patients with clinical symptoms of trigeminal neuralgia are associated with the presence of an epidermoid cyst. Trigeminal pain is a triggering symptom while patients come to us to seek for help, and the study of choice is magnetic resonance. And the treatment for this specific entity represents a true challenge for the neurosurgeon because there is no consensus about the best treatment options. Here in this image, we have a simple magnetic resonance with axial slide at the level of the bridge in a 3D Fiesta sequence. And here we can see an extraaxial nucleation in the left cisterninal space with displacement of the trigeminal nerve. Well, our objective is to present a case of series of patients operated to remove the epidermoid cyst located in the anterolateral cistern of the brainstem, and also to describe our operative technique. Well, on patient and methods, we have a descriptive retrospective observational study, and it was from January 2011 to October 2020. We studied the medical records of 1,996 patients treated at our institute, and all patients present a clinical and imaging diagnosis of neurovascular compression of the cranial nerve, it manifesting as a trigeminal neuralgia. In any of the two clinical presentations, we know we have paroxysmal pain or typical trigeminal neuralgia or paroxysmal with continuous persistent pain, and other manifestations including facial spasms, glotopharyngeal neuralgia, occipital neuralgia, dysfunctional hyperactive syndrome, or vertigo with tinnitus. And all cases were classified by their three etiologies as classic, idiopathic, or secondary. And we have the distribution by age, gender, pre- and post-operative image studies, post-operative evolution, and the follow-up was 6 months, 12 months, and annually. Well, talking a little bit about our surgical technique. First, we position and bird the patient, marking the craniometric points and position of the patient in the operating room. We mark the retromastoid surgical site. We position the patient with a 0.1 angle with limitation of the neck rotation 2 for 49 angle. In step 2, we made a skin incision. It was about 3 centimeters in the retromastoid region. Then we have a soft tissue dissection, dissecting until we reach the cervix of the skull. In step 4, we disinsertion of the muscular upper nautical plane. And later we do subasterional craniectomy and also a dural. We do the depletion of the posterior fossa and cerebellum. Also, we made the tumor resection. Then we treat in the infant area, and finally we do the duroplasty. In this image, we can see the right Subasterional approach under a microscopic vision. In this picture, we saw a subasterional craniotomy, durotomy, and the exposure of the tumor surface with a pearly appearance in the cerebellopontine angle. And in this one, we see the incision of the pseudocapsule and the bulking of the tumor. And then we deplete of the cerebellum without use of retractors. We see the appearance of the superior venous complex and the cranial nerves priori. And we do the appearance of the tumor bed with exposure of the facial nerve. Well, talking a little bit about our surgical research, we have that of all the 1,996 patients. A secondary etiology was established in 308, of which 29 were epidermoid cyst. We exclude 3 patients who present as epidermal cyst extending to other chiasmatic and supratentorial cistern due to surgical method and risk of operating on them are totally different to the cerebellopontine angle approach. So we left with 26 patients. In this patient, the infratentorial location was determined, and either in the posterior fossa or anterior cistern were located. And only 6 patients underwent surgery in another institution and currently present with residual tumor pain and are going under pharmacologic treatment. Almost immediately after tumor diagnosis, 18 patients were operated at our institution using a minimal invasive technique. The cyst was removed completely or as completely as possible, leaving the implant attached to the bracing or vascular structure due to the high risk of complication or death. The remaining 2 patients were not operated on as their pain continued to be adequately controlled with medication. The total removal of the tumor was achieved in 11 patients with excellent surgical results. A total resection was considered as the removal of the squamous content, the pseudocapsule around the tumor, and its integrated implant. The subtotal resection occurred when the friable content was excised, with visible remains of the pseudocapsule or implant. In the remaining 7 patients, it was decided to remove the implant strongly adherent to the neurovascular structure due to the high risk of causing a neurological lesion. Only 2 patients presented a surgical complication due to cerebrospinal fluid leak that required reopening and duroplasty in other institutions. In 2 patients, an MRI showed residual tumor growth at 1 year as follow-up with a size of 2 cubic centimeters without any clinical manifestation. In the immediate postoperative, we evaluate our patient, and this is a maneuver during the clinical examination of 48 hours after her minimal invasive surgery. And here we can see that the lumbar manner was without any alteration. There are facial and extremity motor integrity. The eye movements are without limitation or of the angles in the conjugated picture. And well, we can see that it's a very entity, but up to 1 to 3% can be a secondary cause of trigeminal neuralgia. In the past, it was said that because it is an entity derived from embryological tissue, it can be present on early stage of life, but now we can see that it can be present on elderly patients too, as we showed you before. And also we can say that it has an excellent and very good immediate postoperative clinical result with respect to tumoral removal. And this MRI is the one I showed you before. In the slide below, this is a postoperative MRI where we can see that the tumor was removed and the cistern is entirely free. Well, in conclusion, in our expert opinion, we consider that the minimal invasive subasterional keyhole approach is an alternative microsurgical approach that should be considered as their first option in a case of cerebropontinangle tumor of the epidermoid cyst type. And due to the rarity of this entity, we recommend that the neurosurgeon interested in treating this subject should be trained in a laboratory with a cadaver software for 3D virtual surgery, and it should go under the mentorship of an expert neurosurgeon to resolve the contingencies of the learning curve. And well, that's all. Thank you for your time.
Thank you very much, Dr. Munoz. That's an excellent presentation, a fantastic, huge series and large number of CPA angle epidermoid. I've got one question, then I'll ask Professor Ayakananjali as well as I see Professor Benedetto Colli, the doyen of Brazilian skull-based surgery there. If we can connect, that would be great. How about you? How much chemical meningitis did you get after, or hydrocephalus eye did you get after removal of these epidermoids? Thanks.
CSF leaks is still a problem in every approach, endoscopic, retrosigmoid.
Dr. Segura, in terms of actual spillage of epidermoid, did you get any chemical meningitis or hydrocephalus in any of the patients? Sorry, your mic, thanks.
Yeah, thank you, Nari. Good morning from Mexico, good evening from London. Not really. From this large series, we have not experienced this chemical meningitis. I know it's a very rare case reported, and in every single case, we, at the beginning, open the pseudo capsule, and never we experienced this chemical meningitis.
That's great. Thanks. Thank you. Maurizio, Ayakananjali, do you have any comments about the approach on?
It's good. In some cases you can use, and these are quite rare cases. So good job.
Well done. Thank you very much, Dr. Munoz. Thank you very much, Professor Segura.